Second white coat. Subscribe and like. Let's learn medicine together.
All right, let's dive right into this explainer and build a rock-solid clinical reasoning pathway for one of the most highly tested nephrotic syndromes out there. Look, if you've ever felt completely overwhelmed by kidney pathologies, you're definitely not alone. It's a lot, but today, we're going to become clinical detectives. We're going to take the clues right in front of us and systematically decode minimal change disease.
Picture this. Here is the exact scene of the crime, a classic board-style vignette that we need to dissect step by step. We've got a 5-year-old boy. He's puffy, generalized edema, and this happened right after a mild upper respiratory infection. But his blood pressure and creatinine, totally normal. His urinalysis, however, shows massive proteinuria with absolutely zero blood. And crucially, that protein is almost entirely albumin. So the big question is, what pathologic change is actually driving all of this?
Here's our game plan for today. We'll unpack the question stem, visualize the pathology, rule out the rest of the options, and finally, lock in your high-yield formula.
Okay, step 1, unpacking the question stem.
The absolute key here is actively translating these symptom clues into medical categories, right? When you see massive proteinuria, your brain should immediately scream nephrotic syndrome. The absolute lack of hematuria, no blood in the urine, confirms we're definitely not dealing with a nephritic picture. Now, the fact that his creatinine is normal is huge. It means his overall kidney filtration function is actually still preserved. The filter isn't broken down, it's just really leaky. And finally, his age. 5 years old is the absolute classic demographic for minimal change disease. What's fascinating here is that the URI didn't directly damage the kidney. Instead, it triggered an abnormal immune response that essentially attacked the kidney's filtration barrier. This is a vital distinction to make. The cold virus didn't just casually travel to the kidney. The infection acted as an immune trigger. It caused T cells to become completely dysregulated and release cytokines, specifically IL-13. Think of these cytokines as the actual culprits. They travel to the kidney, injure the podocytes, and ultimately wipe out the negative charge barrier of the glomerulus.
Let's trace the domino effect of why this kid actually puffed up, starting right from that podocyte injury down to the loss of oncotic pressure. When the podocyte's injured, albumin just slips right through the filter and straight into the urine. And because so much albumin is lost down the drain, the levels of albumin in the blood absolutely plummet. Now remember, albumin is the main protein that holds water inside your blood vessels, what we call oncotic pressure. So when that oncotic pressure drops, fluid simply seeps out of the blood vessels and pools into the surrounding tissues. And bam, that results in the generalized edema we saw in the vignette.
Moving right along to step 2, visualizing the pathology.
Before we get into the microscopic stuff, we really have to understand that losing only albumin is a massive neon sign pointing straight to our diagnosis. We call this selective albuminuria. The kidney filter isn't completely destroyed. If it were, giant proteins like IgG and alpha-2 macroglobulin would be spilling out everywhere too. But they aren't. Only the smaller, negatively charged albumin is escaping. This selectivity is your absolute biggest hint about what exactly is broken.
Let's zoom in and see exactly how the normal, repelling negative charges on the glomerular basement membrane are lost. Normally, you've got these healthy, tall podocyte foot processes and a membrane beautifully lined with negative anions. But in minimal change disease, those foot processes have completely flattened out. We call that effacement, and crucially, those negative charge barriers are just entirely gone. Think of it literally like magnets. Normally, the negative membrane repels the negatively charged albumin. It keeps it exactly where it belongs. But when that charge barrier is wiped out, the albumin spills out selectively. Since albumin relies heavily on that magnetic repulsion to stay in the blood, the exact moment the membrane loses its negative anions, the albumin is free to just drift across the barrier and into the urine.
Okay, this is an absolute classic board trap. The disease's name makes perfect sense when we look at the microscopy. It looks perfectly normal on light microscopy, and even immunofluorescence is totally negative. But under the extreme magnification of electron microscopy, that's where we see the flattened podocyte foot processes. If a question tells you the light microscopy is normal, do not assume the kidney is completely healthy. It's called minimal change disease for a reason. The damage is so microscopic that you absolutely need the massive magnification of an EM to actually see the foot process effacement.
All right, step 3. Ruling out the rest. Let's do a quick suspect lineup. Why is crescent formation a trap? Well, we can confidently eliminate it because crescents indicate rapidly progressive glomerulonephritis. That would present with hematuria and RBC casts, not an isolated albumin loss.
Remember our clinical breakdown from earlier? Our patient had absolutely zero blood in the urine. RPGN is a highly aggressive nephritic syndrome, so the clinical picture just doesn't match our puffy, purely nephrotic 5-year-old.
What about nodular glomerulosclerosis? That's your classic hallmark for diabetic nephropathy. It's a trap meant for an older patient with a long history of diabetes, not a previously healthy 5-year-old kid. While diabetic nephropathy does definitely cause massive proteinuria eventually, the demographic and the trigger are completely wrong here. We have a post-URI child, not an adult with chronic metabolic disease.
We can also rule out thinning of the glomerular basement membrane. That points straight to Alport syndrome or thin basement membrane disease, both of which prominently feature hematuria and often hearing issues. Again, we lean heavily on the absence of blood in the urine. If you see a question about a kid with pee that looks like cola, and maybe some hearing loss on top of it, then you jump to Alport syndrome. But for our patient, this is a super easy elimination.
And finally, tubular necrosis. We can toss this one out because acute tubular necrosis presents with muddy brown casts and acute kidney injury. Our patient had a totally normal creatinine. Normal creatinine means the filter is still maintaining its primary job of clearing waste. It's simply leaking protein. ATN would show a massive spike in creatinine and severe acute kidney failure.
And that brings us to step 4, your high-yield formula.
I need you to burn this exact trigger phrase into your memory, because when you see this specific cluster of clues, your brain should immediately activate the minimal change disease pathway. A child, sudden puffiness right after a cold, selectively leaking albumin, but with otherwise normal kidney function labs. That equation equals minimal change disease every single time. Honestly, it's the ultimate board prep cheat code.
If you take absolutely nothing else away today, just remember this incredibly simple mechanism. The cold is the trigger, the podocytes become leaky due to lost anions, and the leaking albumin causes the edema. It strips away all the complex medical jargon. Kid gets a cold, kidneys become leaky. It perfectly encapsulates the immune trigger and the resulting nephrotic syndrome.
Before we wrap up, I want to leave you with a thought. If we know that T cells and cytokines like IL-13 are the real culprits here, how might future therapies intercept this immune signal before the child's podocytes ever lose their negative charge? Understanding the why doesn't just help you ace an exam, it opens the door to understanding how we might actually cure these diseases in the future. Thanks for joining me on this clinical investigation. Keep actively questioning the clues, and I'll catch you in the next explainer.